Now, washout. Washout is a lot more complex. And I just warn you how much you want to delve into this, because I'll show you what you guys should say, and then I'll show you what you guys need to understand. All right. So how does cardiac output affect volatile washout? And again, we head back to the diagram in Miller's. And what we see here is that for a patient with a low cardiac output, so we follow this line here, and I'm just going to draw it with my red pen. What I was saying is that with desflurane and someone with low cardiac output, what happens is that the washing is quicker. I think we can all agree with that. But then have a look down here. What happens is that the washout is also quicker as well. And if you look at someone with a high cardiac output, so this one here, the wash-in is slower, and then the washout is slower as well. All right. And I know this is where it gets really, really confusing, because this is not what we see, I think, clinically. But this is what you guys should go into the exam with, is that, yes, a low cardiac output equals a faster washout, where your alveolar pressure approaches zero a lot more rapidly. Now, one of the key concepts is, remember what I said, is this idea that what's happening in your alveolar is happening in your brain as well, okay? And this just goes back to that idea of about equilibration between the alveolus and the brain. And this is where I've got the little warning sign here. The assumption for a lot of anesthetists is that at all times, your alveolar pressure equals your brain. This is not true though. And this is a chapter in Miller's. So this talks about the alveolar anesthetic concentration. The alveolar anesthetic concentration is a critically important factor in anesthetic uptake and distribution, because one, it is in rapid, so not the term rapid here. And we know that the term rapid, you know, from the models that I did, rapid is a very relative term, because that was, you know, it was about 30 minutes. You know, rapid to me is about 1 to 2 minutes. But for this term here, rapid is about 20 to 30 minutes, okay? So it is in rapid equilibrium with circulating blood and highly perfused tissues, including target tissues in the CNS. And two, alveolar pressure can be measured in exhaled end-tidal gases. Now, this is the really important bit. Except during periods of rapid change, and they've used the word rapid again, which makes this whole concept very, very confusing. But except during periods of rapid change, the pressure in the alveolus in exhaled breath represents a useful estimate of the anesthetic concentration in the patient's CNS and the highly perfused organs. So this bit here, periods of rapid change. I would argue with you that washout is a period of rapid change. And because washout is a period of rapid change, your alveolar pressure should not be representative of your brain pressure. And I'll show you that through simulations. And this is why it's so difficult. It is so difficult to explain the effect of cardiac output on volatile pharmacokinetics. And it's not something that we see clinically, and that is why it's so difficult for us to reconcile the concepts that we're trying to understand that have been, you know, talked about by other consultants, and even those that we may sort of come across in other textbooks as well. Because I can tell you, and correct me if I'm wrong, but a lot of the prescribed textbooks don't actually talk much about cardiac output and washout, other than perhaps 1 or 2 cursory lines. And I'll show you what those lines are. And this is the line actually. So no textbook or no prescribed textbooks other than Miller's attempts to explain the effect of cardiac output or washout. And Miller's has a line here So increasing ventilation will accelerate clearance. I think we can all agree with that. Whereas increased cardiac output slows clearance because more gas exchange volumes are required to remove anesthetics from the larger blood flow. And when they talk about clearance, it's clearance from the lung. Now, what I think they failed to expand on is whether that clearance of the lung is representative or will correlate with what's happening in the brain, and whether a low cardiac output means that your time to awakening or your time to extubation is quicker. Because I would argue with you from the clinical work that I've done, and I'm sure you can see it yourselves, patient with a low cardiac output, even though that their alveolar pressure is below 0.3 of a Mach, I find that they will actually wake up a lot slower than someone with a high cardiac output. And I'll show you why that could possibly be the case. Okay. So these are the simulations with Gasman, and I won't go through it all in detail again like I did with the washing, but I'll sort of show you the graphs here. And what I've done is, again, the baseline is, it's the end of a 1 hour case with sevoflurane. And this is for that, for a patient with a normal cardiac output at 5 liters per minute with a minute ventilation of 5 liters per minute. And we're going to aim for a Mach awake of approximately 0.3. So that's an end tidal 0.61. It's a semi-closed circuit, 70 kilogram person. Fresh gas flow has increased to 10 liters per minute. Your minute ventilation is 5, and I've just got 3 different cardiac output scenarios. And this is what we see. So let's look at someone with a normal cardiac output first. And we can see that from the time we switch off the anesthetic, so that's at the 1 hour mark, your alveolar partial pressure reaches the Mach awake at approximately 4 minutes. But your vessel rich group, which is where your brain is, reaches Mach awake at approximately 7.5 minutes. Now, look at someone with a low cardiac output. With a low cardiac output, their alveolar partial pressure reaches the Mach awake at approximately 3 minutes. But look at their vessel rich group, which is where their brain is, right? That reaches the threshold at 11 minutes. And same here with someone with a high cardiac output. The alveolar pressure is actually longer. It takes approximately just over 4 minutes for it to reach the Mach awake. But look at the effect site. The effect site reaches Mach awake just under 6 minutes. And I hope you see a pattern here, is that as you increase your cardiac output, all right, the time for your alveolus to reach the threshold for Mach awake increases. So as you increase your cardiac output, the time for your alveolar pressure to reach the threshold for Mach awake increases. But we know that alveolar pressure is not going to be reflective of your brain pressure. And in fact, if you look at the other way, so as you increase your cardiac output, the time it takes for your vessel rich group to reach your Mach awake actually decreases. And I think this is what you see clinically. You see patients with a slow cardiac output, on the machine, reaching that threshold for Mach awake a lot quicker, but yet they're taking a lot longer to wake up. And the reason why we reconcile those ideas is we go, oh, it's because they're a lot more sensitive to a lot of the anesthetic drugs. And that's the primary reason how we reconcile that idea. But it's not the only point. The other point is that the equilibration between alveolus and the brain, because of that rapid change, hasn't occurred. And therefore, that is what is prolonging their anesthetic, okay? Not just the sensitivity to inhalational agents or to anesthetic agents. This was really, really insightful doing this modeling here and actually seeing it in sort of real time. And I think this actually would help me actually understand what I saw clinically. And you know, I've always had the sense that even though I could explain this in terms of the alveolus, I understood what happens at the alveolar level. What I found it hard to reconcile was what I was seeing clinically. And again, you know, I was just putting it all down to that, you know, elderly patients had a much lower threshold, or sort of needed more volatiles to be washed out in order to be awake, versus someone with, you know, someone who's young with a high cardiac output. But doing this modeling here, it made me understand that it's not just alveolar pressure. It's actually the vessel rich group pressure or the brain pressure. And again, these are the compartments at 11 minutes. And this is the observation that I think you'll see, is that this idea that your alveolar pressure equals your brain pressure doesn't hold true in washout. So have a look here. The alveolar pressure does not equal your vessel rich group pressure. And again, your alveolar pressure here does not equal your vessel rich group pressure. This one here is pretty close, okay? So, and this is because this is a patient with high cardiac output. So remember, patients with high cardiac output will reach equilibrations a lot faster, but you know, it's still a little bit further away. Now, the other thing to note is that the pressure in the lung is always less than the pressure in the vessel rich group. In other words, you know, if you see someone with an alveolar pressure of, you know, 0.6, right? It doesn't mean that their brain is 0.6. It probably means their brain is like 0.8 or 0.9. All right. And similar to this, you know, when we've got an alveolar pressure here of 0.2, so you're reading 0.2 on the screen, it could possibly mean if they've got a low cardiac output that they're just about to reach MAC awake, okay, at 0.65. So your alveolar pressure is always less than your pressure in your vessel rich group. And the equilibration that occurs, so in other words, the difference between your alveolar and vessel rich group is inversely proportional to cardiac output. What I mean by that? And what I mean by that is that as you increase your cardiac output, the differences between alveolar and vessel rich group starts decreasing, because equilibration, remember, happens a lot quicker with patients with high cardiac output. So patients with low cardiac output, you can see the difference is 0.43. In patients with a high cardiac output, the difference between alveolar and vessel rich group is 0.04. And in someone with a normal cardiac output, the difference is 0.15. So in summary, the first key concept for washout is that kinetics is such that washout, rightly or wrongly, is defined by what's happening in the lung, okay, the concentration in the lung. And the clearance that occurs from the lung is via minute ventilation and your fresh gas flow. So that if you increase your minute ventilation and increase your fresh gas flow, you decrease the concentration in the lung, okay? And that's represented by here. So that's your clearance, okay? Redistribution is via cardiac output. In other words, what you're bringing back into the lung. And if you decrease your cardiac output, you are going to be decreasing the concentration in the lung. So what I mean by that is that if you've got less delivery of volatile in the lung, all right, this compartment here is able to be cleared a lot more rapidly, versus if you were bringing back a lot more drug back into the lung, then obviously it's gonna take a lot longer to clear what's in the lung. And that's what Miller's was talking about, was that he was saying that if you had an increase in cardiac output, you are gonna get increased redistribution back to the lung. And the only way to ensure that you get similar sort of washout with someone with a low cardiac output is to increase your clearance by increasing your minute ventilation rate, as well as, if you haven't already, increasing your fresh gas flow. Now, this is why, as I said before, it can be confusing. It's because the simple traditional hypothesis is that what's happening in the lung is happening in your arterial blood, is happening in your brain. And there will be a lot of anesthetists out there which will still have this concept with them, okay? And I think that this is important to sort of acknowledge, because obviously if you get that discussion with someone who actually believes that what's happening in the alveolus is a true reflection of what's happening in the brain, then it is important to acknowledge that this is what's been, I think, reconciled, even though it's not sort of described in any sort of major text. I think this is how a lot of anesthetists have, how would I say, interpreted the concepts that have been described to them. And what I mean by that is that a reduction in cardiac output increases the washout of a volatile agent. And by increasing the washout of a volatile agent, theoretically, someone with a low cardiac output should have a faster time to awakening, but we don't see that in clinical practice. Now, the second key concept I want you guys to take away from this is that it is the concentration in your vessel rich group which determines your offset. And that the change in the concentration in the lung is so rapid that equilibration does not occur. And I think the idea of using the word rapid is, probably the wrong word to use when we think about it in terms of washing for a volatile agent, because the rapid equilibration that occurs during washing is occurring in 30 minutes, 20 to 30 minutes. Whereas when we think about washout happens within 10 minutes. And you can see already that is why equilibration has not occurred. And so this idea that your alveolus equals your brain partial pressure, I think is misguided. And if anyone, I guess, was to, argue that point, go back to your definition of what MAC is, okay? So MAC is done at steady state, assuming a constant alveolar concentration for 15 minutes, under the assumption that this allows for an equilibration between the gases in the alveoli, the blood, and the brain. And we know that in washout, that there is no equilibration because it's rapidly changing. And so there is no equilibration, or equilibration has yet to occur between the alveoli, blood, and brain. And then the third key concept is that muscle and fat have minimal impact for a 1 hour case. So the reason for that is that distribution to muscle and fat is kinetically slow compared to clearance from the lung via minute ventilation and fresh gas flow. And what I mean by that is, so like when you switch off an anesthetic, so let's say we've got the lung here, okay, and that is at 2%. Your muscle, depending on your cardiac output, is at 7%, and your fat is at 0.02%. Okay, you can see that there are gradients here between the lung and muscle and fat. And so initially, there's actually distribution to your muscle and fat. But because they're so kinetically slow, they have minimal impact in terms of reducing the concentration in the lung. And the primary way to reduce concentration in the lung is not through distribution, but it's through your minute ventilation and your fresh gas flow. Okay. So distribution to muscle and fat for a 1 hour case, minimal impact in terms of the washout or the time to awakening for most patients. Now, redistribution from muscle to fat, again, is kinetically slow compared to redistribution from the vessel-rich group. So what I mean by that is that you've got your vessel-rich group here, and when the percentage in the lung drops below the percentage in muscle, so let's say that lung drops down to 0.5%. So now you've got a gradient from here to here, okay? And let's say this is at 1%. Okay. The impact of muscle, again, plays a very, very small role, because most of the volatile agent, because of the cardiac output, is going to be coming from your vessel-rich group. And so muscle, again, kinetically slow. And when I say kinetically slow, it's relative to what's happening at your vessel-rich group. So your vessel-rich group, remember, has 75% of your cardiac output, muscle has 20%, and fat 5%. And that is why fat, is almost negligible for 1 hour cases. Muscle and fat may play a role in much, much, much longer cases, like 6 to 12 hours, okay? But that's very few and far in between. I think, for the majority of cases that last an hour, muscle and fat have very, very little role to play. And so let's just apply those ideas to low cardiac output and high cardiac output states. So if you have a patient with a low cardiac output, you get a reduction in redistribution from your vessel-rich group to your lung. Okay, so when you've got your lung here, you've got your vessel-rich group. And what that means is that with a low cardiac output, you get decrease of transfer of drug from vessel-rich group to lung. And what that means is that because your lung is being cleared by minute ventilation and fresh gas flow, that leads to a quicker reduction in your alveolar pressure. And therefore, that explains why there's a faster washout. But remember what I said, is that even though you've got a faster washout, you might actually have a slower time to offset, because most of that drug, remember, because of that low cardiac output, is still within that vessel-rich group. It's still stayed within the vessel-rich group. So this vessel-rich group is still at a higher concentration, even though your alveolar pressure is lower, okay? And so the clinical relevance for this is that, yes, there is a faster time for your alveolar pressure to reach 0. Absolutely, I agree with that. But there is a slower time to emergence. Okay, and the reason for that is because that equilibration has yet to occur. And someone with a high cardiac output, so someone with a high cardiac output, you get increase in redistribution from your vessel-rich group to your lung. So again, let's go back to this idea here where this is your lung, this is your vessel-rich group, and with a high cardiac output, what that means is that you get a lot more transfer of volatile from your vessel-rich group to your lung. And then you get clearance with your minute ventilation and fresh gas flow. And because you're having a lot more volatiles being moved from your vessel-rich group to your lung, that leads to this idea of a slower washout. But because you're actually moving a lot more of that anesthetic agent to be cleared from the vessel-rich group, where your brain is, all right? That means that there becomes a fast equilibration with what's happening in the lung, and that leads to a faster time to offset. And the clinical relevance for this is that, yes, washout is slower. So your alveolar pressure reaches 0 at a much slower pace than when you've got someone with a low cardiac output. But they actually have a faster time to emergence. And the reason for that is because the vessel-rich group partial pressure, or their brain partial pressure, decreases a lot more rapidly, because it reaches equilibration with the lung a lot more rapidly. And this is why cardiac output and volatile pharmacokinetics is so complex. But I hope that you guys get the sense of and appreciate why it's so complex. And, you know, with that, with those really complex ideas there. And I guess the challenge for you is how you're going to incorporate it into an answer, because trying to explain that in a written question is very difficult. Now, would I try to explain it in a written answer? I probably wouldn't. But what I would do instead is that understand those sort of key concepts that kinetic output plays on distribution via its role in the time constant. So remember that time constant is the solubility multiplied by the volume of the compartment divided by kinetic output. And also it plays a role in redistribution of drug from the vessel-rich group back to the lung during the washout phase.